And with today's topic, I chose that we are not going to do a lot of theory, because what mostly you will be interested is how do I transfer the theoretical knowledge, all the science in the background we did in the last 15 years regarding ultrasonic surgery, how do I apply this knowledge and how do I apply these skills which can be easily learned in a very, very quick manner. Once we can travel in person again, we will have to do some workshops in all the countries. The participants come from Australia to Asia Pacific, etc., etc. But for the time being, unfortunately, we can only rely on some real life surgery videos. So instead of doing theory, we will step right into a case which covers, let's say, mostly about 50 to 60% of the cases that we face every day with patients that demand to have implants inserted, but they are lacking bone. Before we start with the surgery, of course, nowadays we need a proper planning. Until 2010, 2011, of course, Cbct technology was not that advanced. The pictures were blurry, the pictures contained a lot of artifacts, and of course, the devices to take CBCTs have been extremely expensive. So only highly specialized clinics and chains of dentistry studios, etc., were able to afford CBCT scanners. But nowadays, and believe me, since I use it since 2014, it's almost impossible to do a precise planning without CBCT anymore. Of course, the simple cases with periapical radiography, you can manage most of the times just with 2D representation. But once it comes to simple procedures, nowadays simple procedures and very common procedures like sinus lifting, I always call it INTRALIFT because we developed this patented technology. Anyway, but when it comes to sinus lifting, of course, we need to know what is the anatomy of the sinus. And this is where CBCT technology steps in as a first step in atraumatic surgery to prevent perforations of the sinus membrane and to prevent intraoperative surprises for the surgeon. So let's take a look at the planning of this case. What is the base of this case? What we can see here is there are some remnant teeth up here. There is an endodontically treated teeth, but the patient is wearing a removable overdenture. But what you can see here already is that, of course, the patient wants to receive planets for a fixed bridge. So this is a theoretical planning. You can see here the horizontal cut through the upper alveolar crest and the prospective placement of the implants. In the next slide, you can see the three-dimensional representation because this is one of the big features. You don't have to rely on imagining how the anatomy, how the bone anatomy is under the patient's mucosa covered with the facial tissues, but you can see it and you can turn it around in all aspects to see and to check as if you would already do the surgery, to give you an impression what you have to await during surgery. It doesn't give you surprises. It's like when you're traveling to a country and you just book a flight, let's say to Australia, to a certain hotel, and you see the hotel the first time. When you come here, you might be a little bit misoriented because maybe you expected something different. In case, if you see all the nice pictures and maybe a 3D walkthrough through the hotel, you already know, okay, here is the pool, here I will have my breakfast. You already feel familiar, and this is why CBCT technology is so important nowadays, since it is affordable. As you can see in this case, of course, we see that we have a very big sinus cavity, which does not allow to insert implants. And this is also another big discussion in general implantology. Why don't we use short implants? Believe me, one thing is for sure. Millions of years of evolution gave the current teeth of the mammal human being a certain shape and a certain dimension, because we are speaking about biological tissues, and biological tissues are also somehow technical tissues. That means if you have a piece of wood that is very, very soft, of course, the wood has not the same mechanical properties like really hard oak wood. And this is where we have to reconsider that, for instance, the mandible, it's D1 bone quality. It's a very strong bone, but especially in the upper jaw, in the maxilla, you have mostly D2 or D3 bone quality. So the problem is that we cannot use short implants. We are discussing now 3mm implants, 4mm implants, 6mm implants. If the bone could endure the constant load with such short implants, evolution would have made the teeth roots already very, very short, because evolution is much more intelligent than human beings, as we can see by the state of our small little planet, which we are now surrounded virtually in this webinar. So when we talk about the anterior part of the alveolar crest, you can see here it's too small to sustain, let's say, serious implants. So the minimum diameter of a serious implant in the upper incisor region and premolar region would be around 3.5, 3.8 millimeters to sustain the chewing loads and the parafunction loads over a long time. And this is what I can tell you from 30 years of experience in implantology. Fortunately, my overall success rate in implantology is quite high, because I was trained already some 30 years ago by the big masters of implantology in Germany some 30 years ago. And they insisted and they compared what is the root length, what is the total surface of an implant in contact to the bone compared to natural teeth. And they insisted always take the longmost implant with the widest diameter. For long-term success, when you read the studies about short implants, you will read, oh, what is the 1-year success rate? What is the 2-year success rate? What is the 5-year success rate? Of course, this is science. This is evidence-based. The problem we have with it is it has only partially something to do with real life, because from my personal experience as a clinician and having treated a lot of patients, it's approximately 15 to 20,000 implants in the last 30 years. I know that patients that have an implant failure, even after 20 years, they come back and they will ask you, what are we going to do now? The problem with lost implants is always, you didn't lose the implant, you lost the bone, and the effect of the lost bone was losing the implant. So, of course, if you take very short implants, then of course you will lose them much earlier. So 5-year success rate is nice, but in real life, for a patient, 5 years are nothing. And when we take especially this case, we have to consider the fact that we need a 3.5 implant diameter minimum. We need additional 2 millimeters on the buccal aspect and another millimeter on the palatal aspect. So in this case, of course, we need to do bone augmentation to apply a sustainable implant, which hopefully will stay there for at least 20, 25 years or 30 years. Here again, of course, the different parts of the lateral atrophic alveolar crest, they differ in the width. Here we already have less than the minimum 3.5 millimeter alveolar crest. And if we go further to the back, we have only 2.96 millimeters. So this is just to give you an idea how the situation is in the anterior part. And now we get to the posterior part, which gives us a height of 4.5 millimeters under the sinus cavity. even if you are a fan and you insist on that you are very successful long-term, even maybe for 20 years with short implants, because there are already some companies that try to sell you 4 mm short implants, and they pretend that you will have long-term success with this. As a scientist, I have to tell you the truth, and I'm sorry to use now bad words, but this is what we call bull. You know what I want to say. Because from the standpoint of the bone, it is bull. Why? Because the bone is not made to sustain forces, chewing forces, only distributed over such a small surface. Why do the companies try to sell you short implants? Simply because they want to sell, and they don't take care about the fate of the patient and your legal fate in case something happens. They just want to sell, and they pretend that you can also have also integrated implants of 4.5 mm. Well, that's true. And as long as the implants are not loaded, they will also integrate, of course. But how does the bone react at overload? We know this now very, very long time. And if you're a dentist who is not only doing oral surgery, but also orthodontics, you know that you have to put directed forces onto a tooth to move it. Why does the tooth move? Simply because if you exert constant pressure on the tooth, the adjacent bone will resorb. And since with a natural tooth we have a periodontal ligament, the bone will grow, but we are losing length of the root and we are losing crestal bone. Because if you overload bone, it resorbs. But contrary to a natural tooth, of course, you don't have a periodontal ligament. So that means there is no appositional bone growth if there is a constant load on the bone, a constant overload on the bone. So please do not rely on fairy tales that you can have sustainable results long-term with very short implants, especially not with single molars or even with combined implants with combined bridges. It's not possible long-term, and we know this already, but as you know, these rumors are kept down in the interest of implant industry. So unfortunately, I have to tell you one simple truth. Nowadays, especially, of course, we have different situations in different areas, because in Europe, for instance, the sinuses are absolutely big. Sometimes they already extend to the canine area, to the second incisor area, and the remaining alveolar crest is very low. It's a little bit better in Asia. This I know because we are having a training program at the university in Vientiane, where we see a lot of patients that have quite high bone alveolar crests and very small sinuses. So maybe in some parts of Asia, the need for sinus lifting is not that high. But what we always see, and this is most important, we always see too narrow alveolar crests. And for this, from my experience and from my teaching all over the world and having workshops and courses and live surgeries, the lateral atrophy in Asian countries is much more a problem than, for instance, in European countries. But this is just an impression. I didn't make a serious statistics about it. So this is not evidence-based. This is just my experience. So as the first step, of course, we want to know where is the optimal position for the implants. So this is another feature of modern CBCT technology, especially with the most modern and the most precise devices like the X-Mind Triumph, which I chose for my clinic, because you can insert the implant virtually. That means you have the complete oversight and you are able for the first time to do a retro-engineering. Because what is the most important thing in this issue? It's simply the result. The result is always a crown or a bridge or a prosthetic treatment of any kind. So what you have to do first is you have to match where is the optimum position for the bridge, for the prosthetic treatment. And then you reverse engineer what resultantly will be the best position for the implants. And this you can do now without even touching the patient in 3D reconstructions and 3D simulations of the entire surgery. Unfortunately, it would lead a little bit too far to give you now a step-by-step advice how every step is done. This will be part of some training program when we get to how to manage cases based on CBCT planning. So here you see another imagined implant at the right position, at the right angulation. And even more important, the newest generation. And right now, I think it's still an exclusive feature of the X-Mind Triumph series, which I use and which I would never change for another CBCT device because of its precision, is simply the fact that with this device, for the first time, you're able to determine the bone quality. And of course, nobody wants to calculate Hounsfield values. Maybe you can see it down here. Here you can see the average bone density. And the bone density gives you very good information about your decision. Can I insert the implants primary stable, if there is enough bone, or even can I load the implants immediately? And not to make things too complicated for the practitioner, this device allows you to visualize the bone quality, not by mere values. As you can see here, all these small little values, they always give you the precise number of Hounsfield units of the calcification and the bone density. No, you just take a simple look at the projection of the implant you want to insert, and you see if it's greenish or really highly green, there you have absolute perfect bone quality. You can see it here. Of course, you see it also by the gray tone value, that the compact bone here is highly green. But you can also see that in some parts around the implant, you can await a good bone quality. Since we already know from evidence-based and from experimental investigations, this was done already since 10 years. We know the values that are responsible for good primary implant stability. The software of this device gives you the idea, okay, if it's green, it's primary stable. If it's red, of course, in this case, it is red because the projection of the apex of the implant is inside the sinus cavity and the sinus cavity is empty. If it's red like this, of course, a immediate loading or a primary stability is not given. Okay, here you can see, and for each level of the implant, you will be able to check the bone quality, not only vertical, but horizontal. So, as a basic summary, we know that the patient will need a lateral augmentation in the anterior incisor part and premolar part of the narrow alveolar crest, and the patient will need a vertical augmentation in the manner of a sinus lift. What would have been the traditional way? First, we would have done some lateral appositional alveolar ridge augmentation. So we removed some bone blocks from the chin or from the lateral side of the mandible. We transplanted it to the upper jaw. Then we fixed it, we immobilized it with screws, with osteosynthesis screws. Then we closed again. If we are lucky, we don't have any dehiscencies, because if the dead bone, and another issue I want to clear up, and unfortunately I always have to repeat myself, I don't have enough time in this webinar to give you the scientific background, the hard facts, the publications. But for this you have to trust me, because it's part of other of my lectures where I can show you the histologies. When you remove an autologous bone block from the chin or from the lateral side of the mandible or wherever from the human body, as soon as it is disconnected from the blood vessel, from the blood circulation, after 3 hours, it is dead bone. And this was proven not by dentists who dream about some bioactivity of dead bone blocks. No, it was proven by orthopedic surgeons that have the same problems because they are dealing with the same bone that we are dealing with. And they were proving to the ultimate extent that autologous bone block grafting has no biological activity. It's just a placeholder. So what you are transplanting here will always be a dead bone block. And we know from experience, and we proved this also, I will show you a little bit later on, in a comparative randomized clinical trial that, of course, you have procedural resorptions. And if you listen carefully to lecturers at some congresses, you will always see, okay, they transplant an autologous bone block, they screw it, and then they place some synthetic bone graft or artificial bone graft around. Why do they do this? Because they perfectly know the autologous bone block is resorbed sometimes by 50%. But why was the autologous bone block the gold standard for a very long time? Just a simple fact. If you need the bone to heal perfectly, you need the augmentation site to be completely immobilized, like a natural fracture of a bone. And of course, this is given if you transplant an autologous bone block, simply by placing the bone block and stabilizing it with the osteosynthesis screw. So far to the lateral appositional augmentation, the traditional, or as I call it now, the old-fashioned protocol, because it's not the gold standard anymore. Of course, we have maximal traumaticity, uncalculable outcome, and the treatment time is, of course, longer than 9 months. Second, we need to augment the alveolar crest in the manner of a sinus lift in the molar area. Of course, the lateral approach also provides maximal traumaticity. You can see here by simply detaching the periosteum, which is the only carrier of bone regeneration. You have to move it high up. You detach the periosteum from the bone. That means all the bone area here with the lateral approach sinus lift is disconnected from nutrition. And simply by disconnecting the nutrition from the bone means you will have procedural resorptions because the blood vessels need to reconnect until the bone is perfused again. And in the meanwhile, you will have resorptions. So, of course, this is not the way this kind of surgery should be done nowadays. What is the alternative? It's the new gold standard, the execution with piezotome surgery. And in this case, we use two methods that my research team, Professor Marcel Wainwright, Professor Andreas Kurek, and me developed already back in 2006 and 2009. It's the INTRALIFT procedure and the Piezotome Crest Split. Down here, you will always find some references where we publish this. So what is the simultaneous, almost flapless transcrestal hydrodynamic ultrasonic cavitational sinus lift, INTRALIFT? To give you a basic idea, it's instead of doing a big flap on the buccal aspect of the sinus, you just do a transcrestal approach. The transcrestal approach, referring to the Summers technique, is very limited. You can achieve augmentation heights of 2 or 3 millimeters. Instead, with the INTRALIFT that we developed, you can feel the entire sinus floor, from the back to the front, with one single 2.8 millimeter approach. And to give you an idea on the clinical side, this is how it looks from inside the sinus when you do an INTRALIFT with the cavitation effect. So initially, the tip is building up a pressure, you have the cavitation effect, and suddenly, after a certain temperature rise, a pressure rise, you will see it now, plop, the entire sinus membrane from the entire sinus floor, from the canine region or premolar region to the molar region, is detached. And the perforation risk is much lower than with lateral approach sinus lift. And all this you can achieve through a 2.8 millimeter hole transcrestal approach. The second surgical procedure is the crest split, which is already well known, but which was very, very difficult to perform with rotary instruments, because rotary instruments are round, and of course, you will never have a precise shape. And rotary instruments have an enormous procedural bone loss. So with this technique we developed in cooperation with Acteon, including these special tips, for the first time in your professional life, you will be able to cut bone absolutely bone lossless. I mean, just imagine when you cut an autologous bone block with rotary instruments, how much bone you lose simply by preparing the bone block. That means not so much is left over for the autologous bone block transfer. And with the crest split, we utilize a very simple biological model. You just have to imagine if you extract the tooth, it fills with a blood clot and it gets bone. We don't lose any thought about it because it's so natural for us. We do it every day, or hopefully we can preserve the teeth much longer. But once in a while, we have to extract the tooth, which then leads to lateral atrophy firsthand, which then makes necessary autologous bone block transfer or crest splitting. What we use here is a simple biological procedure that happens every day when you have an accident and you fracture a bone. Instead of putting some bone graft or autologous bone block on the buccal side of the compactor of the lateral atrophic alveolar crest, you simply split the vital bone into two bone plates. You squeeze them open, and both bone plates, the buccal side and the lingual side, they are fully vital. And then you just place some implants, you place some bone graft. And what the body does is, because the bone does not know that this fracture was done by a dentist. You always have to see issues from the standpoint of the bone. From the standpoint of the bone, this is a simple fracture. The bone doesn't care if you just fell down and broke your jaw, or if you as a dentist or oral surgeon or oral maxillofacial surgeon just split the bone artificially. It's a fracture. If a fracture is immobilized and if the bone is nurtured by blood vessels and the bone is vital, there is a blood circulation, then of course the intention of the bone is always to heal. The only thing you have to prevent is an infection. So we also investigated this, and this was presented back in 2017. It was a let's get back to the first topic here, which you will also see then in the surgical video. It's the INTRALIFT, because the term transcrestal hydrodynamic ultrasonic cavitation slicer is a little bit too long. So we did a randomized clinical study. We compared the classic traditional lateral approach sinus lift with the INTRALIFT. And I give you here now a short overview. This video might be still a little bit choppy because I have to then switch over to a different mode, but this video is a little bit too short, but I think you can see the issue. With diamond-coated tips, you just do a pilot drill, like you would do with rotary instruments. Of course, in this case, you don't lose bone, you condense the bone. And this is one of the most important features. You're not removing bone, you're condensing bone. With the second tip, which has a half bowl shape on the top, you open the sinus floor. Of course, it's not 100% safe. If you push, the sinus main is ruptured, but by the cavitation effect and the soft tissue protection of the ultrasonic surgical devices of Piezotome Cube, Piezotome 2, whatever you have, it's very difficult to set a perforation. Much more easy, you can do a perforation. And now comes the critical part. Instead of scratching the sinus membrane off, you just press water in between the sinus membrane and the bone, and you have the addition of the cavitation effect. For this, I will have a special webinar, what the cavitation effect is. And now within 5 seconds, if you follow precisely the protocol, and you have to follow the protocol because this is a calibrated procedure. You're not supposed to change anything in this surgical protocol to be successful. So once it is detached, of course, you need to fill the bone graft. For this, there is another tip that we place here to widen the approach, the transcrestal approach, to 2.8 millimeters. And then I admit this takes the longest time because it's just a very, very small transcrestal approach, 2.8 millimeters. It takes some time until you can fill the subantral scaffold. In case you have enough remaining bone, you can insert the implant immediately. And then after some 6 to 7 months, you can load the implant. So this is just to give you an idea how this transcrestal ultrasonic sinus lift, shortly called INTRALIFT, basically works. What were the results of our randomized clinical trial? So when we speak about the number of sinus lift procedures with the INTRALIFT, we did more than 1,000, and with the lateral approach, to be statistically comparable, we also did more than 1,000 cases, which is then one of the most valid investigations, because it's one thing to have 50 patients in one group, 50 patients in another group. This gives you maybe some statistical significance, but with more than 1,000 patients investigated, this is scientific safety. So when we take a look at the number of membrane perforations, because we should never forget there is no 100% safe method, but when you take a look at the differences between the perforation rate with the INTRALIFT, which is 5.6%, that means, let's be generous, 6 patients out of 100, and with lateral approach, 14%. And I always remind you, if you carefully read the literature, you will see reports of sinus membrane perforations up to 25–30% at some investigation locations, even great universities where ENT doctors then checked the sinus membrane intactness after the surgery by the oral maxillofacial surgeons. So of course, we have 3 times higher safety against perforation with the INTRALIFT method than with the lateral approach method. How many procedures did we have to abort due to sinus membrane perforations? Of course, we know that small perforations we can cover with PRF. I personally always use PRF if I have a sinus membrane perforation. But at a certain stage, if there is a complete rip through the sinus membrane, of course, then you will have to abort the procedure and tell the patient, okay, let's give it another try, maybe in about 3 or 4 months. So when you take a look at the aborted procedure rate, this is half as much as we had in lateral approach technique. The osteotomy time, of course, with the INTRALIFT, since it's a simple transcrestal approach, is significantly lower than with the lateral approach technique. But, and here comes now the back step. Of course, if you have a big bone window with the lateral approach, the filling of the bone graft material, of course, is much faster. So unfortunately for the filling of the scaffold, and these were not small scaffolds, it was scaffolds, you will see it now in the next slide, of 2 cubic centimeters approximately. Of course, the duration to fill the bone graft into the subantral scaffold is double time as long as with the lateral approach sinus lift. And as you can see here, the average volume of the scaffold filled was approximately 2 cubic centimeters or 2 milliliters. What was the result of the study? When we speak the achieved augmentation heights, that means the volume that is preserved then to later receive the implants, there is no significant difference between the traumatic lateral approach and the minimal invasive atraumatic INTRALIFT. But the big difference is when it comes to morbidity assessment, because we investigated also, because it's a clinical study and we want to know how does the patient feel, how does the patient perceive the entire procedure, how does he feel afterwards, how fast can he go back to work or get his social activities. Not in COVID pandemic, now it doesn't matter right now, but there will be times after COVID. So you can see less than half of the morbidity that the patient has to endure when we do lateral approach sinus lifting. Now let's get to the second part of the surgery, and I don't want to put the tension too much, but you need some basic scientific background to understand now then the surgery, which I will have to comment because my comments in this video were in German. We did a randomized clinical trial regarding the Piezotome Crest Split, which my research group developed, versus the traditional buccal autologous only grafts. It was published back in, when was this? It was in Vienna in 2018 and published in Clinical Oral Implants Research, issue 29. So what is the crest split with the piezotome? First of all, the big difference to traditional crest splits when we compare the different methods is we need a certain alveolar crest height, remaining alveolar crest height over the mandibular nerve. But instead of creating a full mucoperiosteal flap, we do it flapless. We just open a small little booklet flap on top of the alveolar crest and keep the buccal bone plate and the lingual bone plate attached to the periosteum. That means we speak about vital bone. First step, we do a mesiodistal osteotomy between the adjacent teeth down to a depth of 8 millimeters. Please also follow precisely the protocol because it took us a very long time, experimental studies, clinical studies, to find out what is the most safe procedure in your hands to be successful with your first 10, 15 cases. Once you're trained to the methods, and we call it you speak with the bone, then of course you are free to change the protocol to your personal liking. So what we did first was the initial widening of the osteotomy, which is almost bone loss, which is definitely bone lossless. But then is one very important step, which you are not supposed anytime to skip, because you need to create a door blade. So you have to do buccal relief osteotomies down to 8 millimeters, the same as the mesiodistal osteotomy, because now you use the elasticity of the bone to squeeze it open step by step. And this is why I have to go down to 8 millimeters, because in another study, which we published in Surgical Device Development Journal, we found out that if you go only 6 millimeters, the fracture rate at the baseline here is much higher than with 8 millimeters, because it depends on the elasticity of the bone. And to further prevent any iatrogenic fracture by using chisels or whatsoever, we created these tips that slowly, step by step, are widening the bone. So the fracture risk with this method is almost zero. I mean, actually, it's evidence-based, and by the clinical studies, it's about 1.5%, but that means 1 patient out of 100. And only in the extreme cases that you will be able to manage once you're very well trained with this method, because then you can split a 1 millimeter wide alveolar crest and widen it up to 5 millimeters. So step by step, we widen up the alveolar crest. And when you do this for the first time, you will see whenever you leave the tip out of the crest split area, the bone will go back again because bone is elastic. So in most cases, you will be able, and you are supposed to insert the implants immediately, because they work as door stoppers. They prevent that the bone squeezes back again and gets narrow again. Then you put some bone graft, you do the wound closure, and you're fine. And after 3, depending on the primary implant stability, you will be able to load these implants within, let's say, 4 to 5 months. What was the result of this clinical study? Flapless Piezotome Crest Split is a significant less traumatic alternative to buccal onlay grafting with autologous bone blocks. Flapless Piezotome Crest Split achieves better results regarding final horizontal alveolar crest width, because, of course, since you're using the innate biological activity of healing bone, you have no procedural resorption, because nowhere you have dead bone. With autologous bone block grafting, you're dealing with dead bone blocks. And once again, please don't hope that an autologous bone block disconnected from blood vessels at the transplantation does have any biological activity, because this is known since 1960 of the last century, which was investigated by orthopedic surgeons, which are tackling with the same problems everything is dead in this bone. There is no biological activity. And of course, once again, Flapless Piezotome Crest Split provides significant less surgery time consumption and post-surgical morbidity. So enough now with theory. I will just unshare the screen now. Okay, you see me again, and then I will reshare. But now I optimize for video. Okay, now you should see again, and let's start. So I already presented you the case you've seen before in the CBCT planning. We have a narrow alveolar crest in the upper incisor alveolar ridge area and premolar alveolar ridge area, and we have only remaining 4 to 4.5 millimeter of subantral alveolar crest height. So what we have to do here is, instead of doing autologous bone block grafting and lateral approach sinus lifting, which of course you could do simultaneously, but which is let's say with the traditional methods, it's very prone to big failures because it's just a too big surgical site. We do here minimum invasive procedure. So we started with a mesiodistal mucoperiosteal incision from the incisor area to the second molar area. And now we are already at the stage of preparation of the transcrestal approach. And since we know we want to insert 2 implants, we start always, and please, this is very important because I already know that maybe afterwards in the chat, you will ask the question, but can I do it via 2 holes? No, the very, very beginning of the INTRALIFT is only by 1 single hole. Of course, you see a second hole here, but this second hole was only the marking of the placement of the implant. The real INTRALIFT we do only by 1 single transcrestal approach. And you see, for you, it might seem now so slow. Oh my God, nothing is happening. There is no bleeding. The sound is like calculus removal. Of course, you have to be careful. At the beginning, you know you have 4 millimeters, and you see here the laser markings. You know how far you can get in forcefully. But on the last millimeter, please be gentle, because suddenly the bone is opened, and then if you put too much hand pressure, of course, you will perforate the membrane also with the INTRALIFT procedure. Because unfortunately, we still have to deal with the very, very delicate sinus membrane. So once you open the sinus floor, hopefully you can see it. Even if the sinus membrane is not detached already, you see a slight movement synchronous with the breathing of the patient, because there's always some criticism that you have not so much control over the surgical procedures because you don't see. No, but you can use indirect signs of being effective, because if the blood column or the saline solution moves synchronous with the breath of the patient, of course, you know the sinus floor is open, but since there are no gas bubbles or air bubbles, the sinus membrane is intact. And now this is important. You see here, the diameter of this tip is 0.2 millimeters smaller than the final tip with which we do the elevation. And this one you just put on top to prepare a ventral seat. And you just go in for about 0.5 millimeters or 1 millimeter maximum. Of course, if the remaining alveolar crest is only 1 millimeter, you just have to touch it, because then comes another step. It's the safety sponge. It has nothing to do with the basic principle, but it's just if you forget to switch the mode on the piezotome and you have a very strong water beam, you still can perforate the membrane with a strong water beam if you don't follow the protocol or you forget to switch from high flow beam to low flow beam. And now you see it snugly fits inside the ventral seat preparation. You check everything, mode D3, 30 milliliters per minute, and then you start to count 5 seconds. 21, 22, 23, 24, 25, and you're done. And now what you can see is the patient still breathes, fortunately, because the patient is alive. And you can see already all the water you pumped between the sinus membrane and the sinus base is flowing back, and there are no gas bubbles. That means another proof. You don't have to see the membrane to know that it's not perforated. You simply do the Valsalva test, but be careful. Don't close the nostril of the patient. Mostly you can see it by the breath synchronous movement and by the outflow of the saline solution you pumped in between. So this is your control. Of course, you can gently take a sinus probe and touch the sinus membrane to have some haptic feedback. But anyway, however you do it, always keep in mind, sinus membrane, even if it's already loose, it can still be perforated, especially when you now do the next step. Mostly I use the TKW2 tips for preparing the site for the implant, but in this case, we take a wider diameter because the diameter of the TKW4 tip is 2.8 millimeters. This would be too narrow for this almost 5 millimeter diameter implant. So, of course, we use the drill, and every implant system has its own philosophy. So you have to use the final drill for your specific implant system. And once again, you can see the patient is breathing. At inhaling, the saline solution goes in. At exhaling, the saline solution is pressed out of the intact subantral scaffold. So then we're going to place the bone graft material. And as you can see, we have only one small approach. In this case, it's a little bit wider than 2.8 millimeters because we use the drill. And I have to repeat myself. When you use the drill, please be careful. You know you have 4 millimeters of remaining alveolar crest height. And if you have a bad coincidence, you drill in, let's say, for 6 or 8 millimeters, and the patient exhales. High pressure is built up in the sinus cavity. The already loose unperforated membrane then is pressed against the rotating drill, and then you have a secondary perforation. And this would be a pity because this then would jeopardize the entire procedure. Now, another very important issue is when you fill the bone graft material and you do not insert an implant, you can be 100% sure by the mathematics and by the geometry, and you always know if you do the intralift, you will always create a minimum 2 cubic centimeter subantral scaffold. Now, but then you take 2 cubic centimeters or 2 milliliters of bone graft, you push it in, and you know you're fine. But if you insert an implant simultaneously, the story is different. Why? Because always keep in mind, also the implant consumes volume. So if you now place in 2 milliliters of bone graft material and then insert the implant, you enlarge the volume, and suddenly the patient will tell you, oh, doctor, I think something ripped inside my sinus, because you didn't subtract the volume from the volume you applied to the sinus, to the subantral scaffold. So always keep in mind, implants consume volume, so you have to subtract the volume from the amount of bone graft you apply. Now, as you can see, in the marking position of the mesial implant, we did now some initial drilling to be a little bit faster, because you don't have to worry. The sinus membrane is already separated from the sinus floor. So even if you drill until the sinus floor, chances are low that you might have a perforation. But I always want to stay on the safe side. Why not taking this 1 single minute or maybe 30 seconds to once again open the sinus floor with the diamond-coated drill? Sometimes doctors, especially with the first generation of piezotomes, doctors always said to me, oh, but it's so slow. But nobody tells you, or there is no evidence that fast surgery is the better surgery. Precise surgery is the better surgery. And if it takes you 30 seconds longer, take the 30 seconds to open the sinus floor, the second transcrestal approach for the second implant with a diamond-coated tip, please. Then, of course, if you feel better, because technically and physically speaking, it's not necessary, you can apply some additional amount of bone graft and then insert the implant. And all this, we filled the entire sinus floor. You will see then in the results part, when we do the post-surgical Cbct investigation, all this, if there would not be the lateral atrophic alveolar crest, this would have been done by a single mesiodistal incision and a booklet flap. No detachment of the surrounding bone from the nurturing periosteum. And actually, in this case, in real time, it took 38 minutes. But you filled the entire sinus floor and you inserted simultaneously 2 implants, which then can be loaded approximately after 6 to 7 months. But now we have to do the second step, and instead of now going to do some autologous bone block grafting, which, by the way, can also be done much more easy and much more precise with the piezotome, especially when it comes to preparing the block graft from the chin or lateral side of the mandible. But in this case, of course, we also go for atraumatic. That means we just have a mesiodistal incision on top of the alveolar crest, and we just open a small booklet flap. We call it because it opens like a booklet, but we don't detach the periosteum from the buccal bone plate and not from the palatal bone plate. So whatever we do with this bone, as long as it is attached to the periosteum, it's vital bone. And this is because this is also why I like especially this surgical live surgery video, because this is another feature which you can only achieve with piezotomes. You can cut, you can do osteotomies around a curve, because with rotary instruments, even with chisels, this is impossible. Just imagine a rotary diamond coated wheel. How do you want to go around? How do you want to have a precise rectangular osteotomy? And of course, also the diamond coated wheel, rotary instrument, has to have a certain width, which is approximately 0.5 to 1 millimeter to be sufficient in doing the osteotomy. In this case, you cut the bone lossless. You see, you just open the gap, but there is no bone wasted by the preparation. If you ask yourself, what is this? This was a prior socket preservation when the tooth was extracted some years ago. But of course, it was not sufficient, as you can see, because in case it would have been sufficient, the bone would have been much wider there. So we could have placed the implant directly into this preserved socket, so far to see that a lot of times alveolar ridge preservation after tooth extraction might not lead to the desired result of having bone dimensions that allow a simple implant insertion. And once again, you see there is almost no bleeding, there is sound, there is no stress because you don't need much hand forces. Of course, it will look or it will make you feel boring. It's completely different if you have to tame a rotary instrument that wants to go to paths that you do not want to the instrument to go to, or if you just simply hold the instrument in your hand without much force and you go bzzz, the typical sound of the piezotome. And you see, of course, there's progression, and you can see here, this is real time. This osteotomy is real time. And if you check your stopwatch, it takes you 2 or 3 minutes. What are 2 or 3 minutes? Nothing, okay? But from your perception, since there is not much action, there is no bleeding, there is no stress on your side because, you know, soft tissue safety, precise cut. Of course, everything seems to take longer if there is no stress you're underlying to. Contrary, with rotary instruments, you're under constant stress. So with rotary instruments, 5 minutes of work seem to be 30 seconds. And 30 seconds of working with piezotome instruments seems to you to have taken 5 minutes. That's the difference, because you can be relaxed and you don't have to fear that you have intrasurgical iatrogenic complications. And now, this is a very, very important part of the whole procedure. If you're in the upper jaw, if you're in the lower jaw, you always, by demand and by surgical protocol, you have to do the buccal relief osteotomy. And I admit, this is going to take the longest time in the entire procedure. Not in the maxilla, because the bone in the maxilla is mostly D2 or D3 quality, but in the mandible. So just calculate for buccal relief osteotomy, mesial and distal of the mesial of the osteotomy, it might take you 2 minutes per osteotomy, because If you do not do this and you just try to squeeze open the crest splitted bone without these relief osteotomies, you will for sure in the maxilla endure undesired accidental vertical fractures. Actually, it doesn't, let's say, compromise the bone healing as long as they are connected to the bone. But if there is then some bone part of the bone plate also disconnected from the periosteum, we are in the same situation as with autologous bone block transfer, because the bone is not vital anymore, it's disconnected. So the buccal relief osteotomies are a must, and you cannot avoid them to be 100% on the safe side. But it's just 4 minutes in the mandible and maybe 2 minutes in the maxilla, as you have seen, because this is almost real time. But since this was a live surgery, of course, I did a lot of comments. I was showing the participants here and there, and this I cut off from the video because, first of all, my comments were in German, so most of you wouldn't understand it. And of course, it's boring because we all know videos should not be too long. So anyway, now we start to squeeze the 2 vital bone plates open by these special tips. If you're already highly advanced with the flapless crest split technique with the piezotome, then of course at the later stage, let's say after some 30, 40, 50 surgical procedures, maybe you will not need these tips anymore. Oh, sorry. Okay, I have to go back because I did a wrong click. Okay. Oh, this is a little bit too far, sorry. No, okay. You have to go back. So where did I stop? Yeah. This with the CS tips number 4, 5, and 6, the risk of having accidental fractures during the distraction process are very, very low. It's about 1% again. But if you're already highly trained after some 40, 50 piezotome crest split, flapless, then of course you might opt or choose to put in a chisel, because then you have the experience, you have the feeling, how does the bone react if I do it manually? Then maybe you will spare this step because it's also a short step. It takes you maybe for this size of the crest split 1 minute per tip, which adds up to 3, let's say 5 minutes. And with the chisel, you can slightly squeeze it open. But for your first 30 to 40 surgical procedures, please, once again, exactly follow the protocol and don't skip any step and don't misadjust the piezotome. You have to use the right adjustments to be successful. But it's very easy. It's written on the leaflet. Now, once the widening is finished, and you can see whenever I put in between the distracted bone plates an instrument, it goes open. But once you leave again, it goes back again because bone is elastic. So it's very important, even with, especially with very, very narrow alveolar crest, you will now ask yourself, but why is this drill so shuddering? Why is it not running smoothly? It's simply because I use it counterclockwise. This is so important. You have a narrow alveolar crest. You have to do the drilling for the implant. If you do it clockwise, drills remove bone. But this is what we are not allowed to do. We do not have to remove bone. So both for the maxilla and the mandible, if you tackle or if you manage alveolar crest width of, let's say, 1 or 2 millimeters, please never let the drill run clockwise, because clockwise running of the drill means removal of the bone. If you let it run counterclockwise, it means just separation of the bone. There is no removal of the bone. And as you can see, an experienced implantology immediately recognizes that I need a lot of force now to insert the implant. What does this mean? The implant is extremely primary stable. Of course, not as stable as for immediate loading, but really sufficient primary stable. Why? Because once again, we insert the implant, which is longer than 8 millimeters. So you achieve primary stability by the remaining alveolar crestal bone, in this case, above the osteotomy site. But also, since the bone is elastic, also the buccal and the lingual bone plate give you additional primary stability. And once again, as you can see, an experienced implantologist knows how it looks when someone else is screwing in implants and he needs a lot of force. So the experienced implantologist might agree now that you can see this is really Newton. Actually, of course, we took the measurement. It was approximately 40 to 45 Newton centimeters insertion torque value, which is above most of the insertion torque values you might achieve with different implant systems. So this is really primary stable, not for immediate loading, but let's say for hassle-free and fear-free osseointegration of the implant. So, of course, now the entire procedure is almost finished. Now we have to remove the insertion parts of the implants. And once again, I remind you, what do we see here? We do see here a narrow alveolar crest in this area. Now you saw the back of my head, and a low alveolar crest in this area. And we did all this, the entire procedure, crest splitting with widening of the alveolar crest to 6 millimeters, 5 to 6 millimeters, plus a sinus lift of the entire sinus through a transcrestal approach without detaching the periosteum. Now, of course, in between the two inserted implants in the crest split, we mostly use the self-hardening bone graft material EasyGraft. Why? Because it's the first autologous bone block analog material, because it's self-hardening. Actually, it's beta-tricalcium phosphate and hydroxyapatite or pure beta-tricalcium phosphate in a formulation that allows self-hardening to. We made another study, and this was published multiple times. You can read it up in our Academy's channel, where you can download all the relevant informations. It's really the first replacement of autologous bone blocks. And of course, in this case, it gives additional primary stability to the implants. So now the cover screws are attached. And now you will ask yourself, yeah, but especially up here in the front, how the hell, now it's wider, how the hell am I going to close the wound without preparing a mucoperiosteal flap and slicing the periosteum? Because periosteum is a holy tissue. It's really a holy tissue because it's the only way the bone can heal. Without periosteum, there is no bone healing. If you remove the periosteum over an intact bone, the bone will go away, because periosteum is the key to successful bone keeping, bone regeneration, and bone remodeling. But we use something very, very simple. Especially in the maxilla, you can see the gingival tissue is very thick. We speak about sometimes 4 to 5 millimeter thickness. And once again, please always be flexible in what you're doing. Now you will ask yourself, what the hell is this guy doing? What is he cutting away? I mean, there is only very little. When you do a autologous connective tissue transplant, you are doing exactly the same. Instead, in this case, we just reduce the thickness of the mucosa. And as you can see, once you reduce the thickness of the mucosa, suddenly you can close it primary closed. And that's the secret behind it. So you just do an autologous connective tissue transplant simulation. Of course, you can use these connective tissue transplants also to cover this area here, which would make sense because we use it to cover areas. In this case, it wasn't necessary, so we just step over to doing the suturing. And for suturing, I personally prefer, because you always have to think of the situation of the patient when you remove the stitches, after 10 to 14 days, that the patient doesn't have local anesthesia for stitch removal. So I personally always prefer the running suture, and this gives also much higher primer stability to the soft tissue healing. And once again, I always have to get back to very, very basic biological rules. A tissue, whatever tissue you're dealing with, might it be lung, might it be bone, might it be skin. Just imagine you cut your skin. You have the bleeding, you have the cover with the fibrin, and then when you move the part of the skin, it gives you pain. Why? Because the body always tells you, please, please immobilize me, because I can only heal if I'm immobilized. And this is also so important for wound closure. The margins of the wounds have to be immobilized as good as possible. And this is a task a general surgeon, abdominal surgeon, orthopedic surgeon, whatever surgeon you might imagine, is very easy, because if it's orthopedic surgery, a leg, an arm, or if it's abdominal surgery, it's the belly, you can immobilize it quite good. But in the oral cavity, immobilization, which is the very, very basic demand for proper wound healing, is very difficult. Why? Because as soon as you finish the surgery, the patient is starting to talk with you. The tongue is touching the area because the patient wants to investigate, oh, what did this guy do here? Oh, it's so funny, I can feel the stitches. How do they feel? Please advise your patients not to play around with the stitches with your tongue, because they mobilize the wound, and this leads to dehiscency. Second of all, of course, the patient wishes to insert the overdenture again, which is a problem by itself, especially in cases like this, where you don't have a periodontal support by distal teeth. And of course, the patient has to chew. It's almost impossible, especially in the mandible, to do a proper immobilization of at the wound closure site. So to overcome this problem, either you can do some stabilizing stitches, or you do a running suture like this with a loop, as you can see here. So you do one single knot, which has the big advantage. The patient has only one knot to play around with the tongue outside the original surgical area. And with the loops, they just sink into the soft tissue, so that the patient is not really motivated to do this. And in some areas, you might see, okay, there is a small dehiscency. Of course, it's not a problem. It's the same dehiscency you have when you just simply extract the tooth. Always imagine what happens. Patient comes in between, patient tells you have pain, you have other things to do, big surgeries, prosthetic preparations, and he says, please, please help me do it now. You say, okay, I know this tooth had to be removed already, so take 5 minutes. Local anesthesia. Meanwhile, you do some other things. Then you just take a plier, you extract the tooth, or even better, nowadays, you should take the piezotome. And then you just tell the patient, okay, go home. In 3 months, we will do a checkup, and then we'll insert an implant. You don't even think about doing some complicated sutures or whatsoever, because the extraction site is filled with blood. And the blood is the very base for vascularization. The vascularization is the very base for the, just to interrupt me, now the entire surgery from the beginning up to here was 84 minutes, 1.5 hours. You don't even think about it, but the immobilization is the key point. And with this type of suture, you achieve this. And if you have small dehiscencies, of course, there will be, I just have to stop the presentation because I have to reshare again without the video optimization, because then the writing gets blurry. Okay, let's start again and switch off this and start this again. Yeah, but what I wanted to tell you is that If there is a little gap open, this will heal by secondary intention. Most of the times, it's only about 1, maximum 2 millimeters. And within 1 or 2 weeks, if the patient does not rinse too extensively like this, or goes over the side with the toothbrush, you don't have to worry about secondary intention, as you don't worry when you just do a simple tooth extraction of a molar where the gap is much wider, because it's filled with a blood clot, and it will heal by secondary intention. Now, to get to an end of this, because we are already a little bit short in time, but I think I still have about 10 minutes. I don't want to overdo it, because sometimes the webinar is announced for 1 hour and I'm doing 2. You might have to do other things. In some parts, it's going to be night. You want to go to sleep. In some other parts of the world, you might have to start work again. So I will make it short. So this is now the final result. It's the depiction of the post-surgical result. You can see here with different filters in the Cbct scan that you can distinguish the implants, the augmentation side, and the implant insertion. This is from a different point of view. And here you can now see the anterior part. What did we achieve? Remember, in the original situation, we had about 3 millimeters, 3.5 millimeters alveolar crest width. And here you perfectly can see, after the split, this is the buccal bone plate that we distracted. This is the palatal bone plate. And now we achieved 7.5 millimeters of alveolar crest width, which is, because this is a 3.8 diameter implant, apically it's 3.5 millimeters. Oh, sorry. Here it's 3.5 millimeters. It's a little bit misprojected. 3.8 millimeters. So we have the additional minimum 2 millimeters on the buccal side. It's the protection against resorption, or if resorption happens, it doesn't expose the neck of the implant. And you have almost 2 millimeters on the palatal side of bone coverage of the implant. This is a perfect result. This is a perfect result, which you can hardly achieve with lateral autologous bone block appositioning in the most least traumatic way for the patient, because once you do only a very simple cut on top of the alveolar crest, of course, there will be almost no swelling and there will be almost no pain. And of course, the surgical procedure with the Piezotome crest split, the Flapless Piezotome crest split, of course, is much faster than lateral apposition of autologous bone blocks. Why? Because all the part where you have to prepare the autologous bone block just falls away, which consumes a lot of time, believe me. So here is then another part. It's just adjacent to the implant. Here we achieved 8 millimeters. Here you can see nicely the distraction gap. And here now, this is the sinus lift side. You see here, this is the basic remaining alveolar crest, 4 millimeter crest height. This is already the cover screw of the implant, but you see here the augmentation from the mesial to the distal side. And it's always, we called it from the very first beginning when we did the development of this surgical technique back in 2005, 2006, we called it the so-called pleasure dome, because the nice thing with the transcrestal intralift also is, and this you can see now in the next slide, since you place the bone graft through the transcrestal approach, the bone graft will itself, by gravity and by simple physics, always distribute evenly around the transcrestal approach side. So you don't have to worry with lateral approach. If you do not place first the bone graft on the palatal side, then insert the implant, and then place the bone graft on the buccal side, you're in trouble, because then here no bone will regenerate. But with the intralift, you always have the implant right in the center of the augmentation by simple physics. It's not something magic, or it's not something not so to be expected. It's simple physics. You place the bone graft through the transcrestal approach, you place the implant into the side, and the bone and the implant will always be perfectly surrounded by the bone graft material. So here is another view. we achieved approximately 6 to 7 millimeter augmentation height. Here you can see the situation before in the planning, the situation after. Of course, if you want to invest additional money, or if you are lucky and you already have, because at this time I didn't have the model or the software at this time was not able to create the surgical guide. But nowadays, if you get the newest generation of X-Mind Triumphs, you will be able to construct your surgical guide by yourself. You spare a lot of money that you would have then to give to a company, so the money stays in your own pocket. You create the surgical guide, and then you can even, if you go one step further, you can buy for 600-700 euros. Unfortunately, it's depending on the law situation in your country. In Austria, it's not possible because I just could buy for 300-400 euros a 3D printer. And with this 3D printer and the X-Mind Triumph software, I can print out my surgical guide. And I have to pay just for the polylactide wires that are used by the 3D printer, which is a few dollars investment. But you don't have to pay an external company or a dental technician to produce the surgical guide. This you can do with the latest generation. And of course, I have cases where I can demonstrate this, but this unfortunately is not part of today's webinar. But as you can see, even if you do it without a surgical guide, let's say the result is quite compelling, because the only difference is that maybe this implant I inserted emotionally a little bit more to the mesial side to have a more even distribution of the implants. But as I tell my students and my postdocs in basic implantology, first you have to learn to insert implants with eye-guided surgery. That means you have to have the orientation helped by the planning on 3D Cbct imaging. You imagine where do I have to insert the implant, and then just by your eyes and by your mind, you have to transfer this knowledge and your planning with your hands to the side. Because it doesn't make sense to say, okay, implantology is just drilling holes. I just take a surgical guide, drill holes. What in case something happens during the surgery, especially during the crest split? You don't follow the protocol, you have some accidental fractures. Then if you are not trained to insert implants without surgical guides, what are you going to do? Because the reaction, the normal human reaction is you're getting in panic, and then of course panic is the best reason to do another failure, and then the whole surgery will be a disaster. So if there are some beginners here in this webinar, please learn to insert implants visually by Dr. Right hand, Dr. Left hand, Dr. Right eye, Dr. Left eye, based on in more complicated cases, based on a 3D Cbct image planning. And only later on, if you tackle very complicated cases where the question is, can I avoid bone augmentation procedure at all if I place the implant a little bit slightly here or slightly there, if I can use angulated implants. For instance, for angulated implants, the bone augmentation-free procedure, all on 4, all on 6, etc., with angulated implants under the sinus cavity, there, of course, you obligatory need surgical guides, because this type of angulation you cannot do with your eyes. So, but you see, the result is quite satisfactory. And here you can see before 2.96 millimeters on the same side. Now we have 7.4 millimeters. Here, 4.5 millimeters. And we achieved additional 6, let's say 7 millimeters to do a rounding, because it's always funny to have 0.01 millimeter measurements. Simply by the artifacts, it's not always so precise. So to get to an end, I just want to introduce you also shortly to my research group. This is Professor Marcel Wainwright. He lives in Germany. This is Professor Andreas Kurek. He also lives in Germany. That's me with some kilos more. And when you like this webinar, I also want to take home just the impression what you can do with piezotomes. Try to just cut out the initials of your name. Of course, in Thailand, it's going to be even more difficult with rotary instruments. It's impossible. Here you can see Tröthan, Kurik, Wainwright. We cut out our initials from a bone. This was a pig's bone. And this you can do with rotary instruments. And I want you to keep this picture in mind. First of all, that we are guys just working in our offices, not only high science, etc., etc. We serve our patients. So this is why we do research for the benefit of our patients. And just take this picture home with you or keep it in your mind because you're at home due to the pandemic. It's impossible to do this with rotary instruments. Okay. And of course, another big issue is you always have to imagine when you are the patient. So if you're unlucky and you have to do some abdominal surgery, would you like the surgeon to cut open your belly like this and just crawl around your intestine? Or would you prefer to have a simple, minimal invasive surgical procedure like this? With this procedure, after 2 or 3 days, you can go back to your office, you can go to the golf course or do whatever you want to. Because minimal invasive means the less you cut, the more success. The less you distract or the less you separate tissue layers from each other. Of course, the less the body has to do the healing. Less traumaticity is the imperative issue of today. So destroying bone to heal bone, it's an absolutely no. So traditional instruments are outserved by the new gold standard in implantology. So I also want to tell you, may the piezotome power be with you always, okay? This is some kind of the core message. Of course, I also want to announce, unfortunately, I cannot give you dates. We do teaching courses on human cadaver heads, and we do teaching courses directly on living patients in Austria at the University of Innsbruck, a very nice town, and one of the most famous universities in Austria. We do it also in Asia, in Vientiane. But unfortunately, due to the COVID pandemic, I cannot give you any dates for this year. There was planned to be a course in Innsbruck this weekend, which we had to cancel. There will be maybe another course planned for October, November, but it depends if Brazilians send us their P1 variant of the COVID virus. And in Vientiane, I cannot tell you, we planned to do a 1-week surgery course on patients around October, but still we don't have the confirmation that this is going to take place. So please take a look at our homepage regularly, and as soon as we know the new dates, you're gladly invited to join us. So I made it almost right on the dot. It's 12:30 here in Austria. So I kept my 1.5 hour of webinar. I want to thank you so much for participating. I hope I was able to show you why piezotome surgery is the new gold standard in dentistry and oral and maxillofacial surgery. I hope there is something you might think about to do with these piezotomes in the future. And I just want to give you also the hint that you can join for free. You don't have to pay. You don't need a password. You can join our academy, our learning channels, where you find this lecture, where you find all the surgery videos, among others, also the surgery videos I presented before the webinar started. You just type in www.jausi.org and you get to the homepage. You choose the learning channel where the PowerPoint presentations are. You choose the video channel where the surgical videos are. And during the pandemic, unfortunately, you will have enough time to get so deep into piezotome surgery that I think that maybe soon I can introduce you to even more advanced techniques. Thank you so much for your participation. Please stay healthy, stay safe, and I wish you all a very, very, very quick vaccination against this virus that busts our balls now for 1 year. Thank you.